Good morning, everyone, from the GUcast studio in Melbourne, Australia, with Professor Declan Murphy, having this wonderful setup, very professional setup, unusual for a surgeon.
Well, unusual for a nuclear medicine physician to be up at 6 o'clock in the morning. I might throw into the it's 6 o'clock in the morning here in Melbourne, but great to have you, Michael. Thank you for popping into the studio.
Thanks for getting all the technical wizardry happening. We've got over 200 people online.
Fantastic. And going up by the minute, I think. How many have you got registered?
Oh, around 1,000.
There you go. Just wonderful. So good morning. Yeah, my name is Declan Murphy. I'm a urologist at Peter MacCallum Cancer Centre. I've the great privilege of working with Michael almost day to day at Peter Mac. And it's been fun. I don't know how many of these PCF, ProsTIC, GUcast webinars we've put together, Michael, but it's been very enjoyable. I've learned a lot from doing them. And my job this morning is really just to welcome you and we'll welcome our studio guests and our panel. And then I'm going to retreat behind the scenes here and just help keep the show on the road while I learn all about the biology of PSMA. I think that's your theme this morning.
Yeah, we're going to unravel PSMA biology.
Prepare to be unraveled, PSMA. I'm looking forward to it.
Absolutely. Very exciting. I didn't introduce myself. I'm Michael Hofman, nuclear medicine physician from Peter Mac in Melbourne. Welcome, everyone. And shall we introduce our special guests and co-host?
Please do.
Co-host number one is Dr. Ed Kwan. Ed is a GU oncologist who's recently returned from Canada. He is from Melbourne, but he's now at Eastern Health and lab head and senior research fellow at Monash University and a PCF young investigator class of 2021. And he's come from Alex Wyatt's group and Kim Chi's group in Vancouver, Canada. So back with a wealth of experience.
Ed, why don't you come over and have a seat here, and I'm going to retreat over here to the corner while you do that.
And our second extra special guest is Dr. Louise Costos, who's a medical oncologist with us at Peter Mac and also doing a Ph.D. With our program, all things Theranostics, leading multiple trials or helping to lead, including LUCAB, Violet, Alphabet. We're keeping you very entertained and busy at Peter Mac.
That's for sure. Thanks so much for having me.
And Ed, welcome.
Yeah, I'm really excited.
All right. Now, for everyone that's joined, this is a very interactive session. We've got 4 stellar speakers, but you can ask questions, and there's a Q&A button on the bottom of your Zoom button. And if you press the Q&A button, you should be able to ask some questions, and then we will run through everyone's questions over time. You can also use the chat to talk to us if needed. I might start with a little poll for the audience. And the question is, how many people from different countries have joined this? I'm just going to post it now. Relaunch poll, continue, yes. How global is Theranostics? And the question is, people from how many countries have joined this webinar today? 0 to 10, 11 to 20, 21 to 39, or more than 40? And this is to check that our voting system works. And we do have around 250 people online. And wow, people think there's people from more than 40 countries. What do you reckon, Ed?
Oh, I wouldn't have thought it was that high, but maybe I'm about to be surprised.
Yeah. Well, we have...
How truly global are we?
How truly global are we? Let's have a look. We have people from 69 countries.
Well off.
That's pretty impressive.
It is.
Yeah. We're almost filling the whole globe, but even continents like South Africa and Africa are lighting up pretty brightly. It's pretty phenomenal. And what's the breakdown? What do you think? Are there medical oncologists, urologists, scientists?
Oh, I've got to reckon that Nuke Med's on top, right?
Nuke Med's on top. It's mainly nuclear medicine specialists and physicians joining, and we have nuclear medicine technologists, medical physicists, but a surprising number of pretty much everything. But a striking figure to me, Declan, was that there are more urologists joining just by a touch than medical oncologists.
Oh, no way.
Ouch.
More urologists than medical oncologists.
And there's
interested in
actually more
PSMA.
radiation oncologists than medical oncologists too. What do you think about that, Louise?
It's too early for the physicians. I think that's the issue.
Wow. I don't know. I'll have to see what Misha thinks about that. You know, how many New York urologists are tuned in here, or East Coast urologists versus medical oncologists?
We might hand over to Howard Soule to say a few words. Howard is generously supporting our program through the Prostate Cancer Foundation. He's Vice President and Chief Scientific Officer of the PCF. And I discovered that he's been with the PCF for 28 years, which is pretty phenomenal. Howard, can you share some wisdom with us?
Thank you, Michael. It's been my honor to serve the patients all over the world with prostate cancer, trying to fund the best science for better outcomes for patients everywhere. I'm really proud to say that you chose a panel of speakers today that have all been funded by PCF, including yourself, as well as many other people at the Peter Mac. So we're very proud of that. We're proud of the role that we have had in advancing Theranostics from a young Martin Pomper at Johns Hopkins School of Medicine all the way through to the approval of Pluvicto, and I think the future is very bright for the discipline. So thank you for organizing this part of your ProsTIC grant.
Thank you, Howard. And we might hand to Andrea, Dr. Andrea Miyahira, who's the Senior Director in Global Research and Scientific Communications at the PCF.
Thank you, Michael, and thank you to the entire panel. I'm excited to see what we're going to learn about today. I always appreciate these ProsTIC webinars. I think they're just a tremendous resource for our community. We really see nuclear medicine grow, and I'm sure the education and how we learn through these ProsTIC webinars is really contributing to that. So thanks, and thanks to everyone. I look forward to it.
Thanks, Andrea. And we might jump straight into our first speaker, Dr. Himisha Beltran from Dana-Farber Cancer Institute, Associate Professor of Medicine at Harvard Medical School, a GU medical oncologist. Misha's program is focused on understanding mechanisms of treatment resistance in prostate cancer and pathogenesis of neuroendocrine prostate cancer in particular. An incredible volume of work you've done there, including cell surface targets with PSMA. Something people might not be aware is that Dana-Farber is a sister institute with Peter Mac. And last week, we did a nuclear medicine technologist exchange with Dana-Farber. We sent Danielle, one of our techs, over to Dana-Farber, and one of your techs is coming to us in a few weeks' time. So this is the first time we've done this. It's been very successful. There's a bit of a global shortage of nuclear medicine technologists, our staff that do our PET scans and really inject our therapies. So we really need to boost this aspect of the discipline so that we can serve the global Theranostics community. So pleased to have that Dana-Farber partnership. But over to you, Misha. You can share your screen, and we really look forward to hearing your presentation.
Yeah. Thank you so much for having me. I've joined these before. It's been, as Andrea said, a tremendous resource, and I feel honored to be invited. And also looking forward to the partnership between our two institutions too in the future. So I will kick us off talking about PSMA heterogeneity and the neuroendocrine axis and how this might influence response and resistance to PSMA targeted therapies. Here are my disclosures. So we're all here today talking about PSMA, a very exciting cell surface biomarker and therapeutic target, but it also has enzymatic function with both folate hydrolase and carboxypeptidase capabilities. And in other organs like the duodenum, the kidney, the brain, it's actually referred to by alternative names reflective of its metabolic activity. And in prostate cancer, this activity can influence downstream genes and pathways that impact cell migration, proliferation, and survival. In the normal prostate, work on looking at in situ analyses and single cell sequencing have illuminated that PSMA is predominantly expressed in luminal type A cells, reflecting its prostateness or hormone dependence. And this is also translated to prostate cancer, where we know that PSMA expression can be dynamic in individual patients and is strongly influenced by androgen targeted agents, ADT, AR targeted therapies, where we can see upregulation of PSMA with acute AR inhibition, as tumors respond, we see downregulation of PSMA, typically reactivation of androgen receptor, which occurs in most castration-resistant prostate cancers, results in overexpression of PSMA. And then in some patients with late stages of disease, we can see loss of PSMA expression, and this has been linked with loss of androgen receptor expression. So there's this really tight relationship between PSMA and the androgen receptor signaling axis in prostate cancer. And this is in part due to regulation of the PSMA gene, FOLH1 gene, by the androgen receptor, which can bind the upstream enhancer, interact with co-regulators to modulate PSMA expression. And in tumors and in model systems, cell lines, PDX models, when we see loss of androgen receptor, we typically see loss of PSMA expression. When we look at the different disease states of prostate cancer, going from benign to localized to CRPC and even later stages of CRPC, we see increased levels of heterogeneity with later stages of the disease reflected in tumor tissues and also by PET imaging. But even in newly diagnosed patients, there can be variability in expression of PSMA. I was intrigued by this recent study by Weiner and colleagues where they looked at PSMA expression by transcriptomic analyses in tumors, correlated that with PET imaging in newly diagnosed hormone-naive patients, and then developed a cutoff based on PET imaging, and then applied that to large data sets, nearly 5,000 tumors with RNA sequencing data available. And again, even in newly diagnosed patients, patients with PSMA low disease had lower AR activity and more basal-like phenotype. It was associated with angiogenesis, hypoxia, reactive oxygen species that made the patients that were treated with potentially modulating radiosensitivity, patients treated with radiation. And in patients on the CHARTED trial, those patients that had PSMA low tumors seemed to benefit most from the addition of docetaxel. So even in early stage prostate cancer, we can see PSMA expression associated with more basal, less AR signaling activation. And then we know in later stages of prostate cancer, a subset of patients we've seen in vision and therapy and in clinical practice develop PSMA negative disease. And these patients are obviously not eligible for lutetium PSMA 617, and they're often FDG avid, reflecting, again, their metabolic differences or changes that we can see in late stages of the disease. And even in PSMA positive lesions, we can see tumor heterogeneity at the tissue level and at the imaging level when thinking about SUV means and other readouts to try to capture this heterogeneity within and across patients. And this is important because heterogeneity of PSMA expression impacts response and resistance to lutetium PSMA therapy seen in preclinical models. And I think is being translated into what we're learning from some of the data sets that many of you here have been leading. So lots of work by my nuclear medicine colleagues to refine PSMA PET imaging as a biomarker to better capture heterogeneity and use this clinically. And I think it's also very important to understand PSMA low or PSMA negative disease as we start thinking about alternative imaging biomarkers, alternative treatment strategies, or combination approaches. And one mechanism of loss of PSMA is through histologic transformation from a AR-driven prostate adenocarcinoma to a small cell neuroendocrine prostate cancer. This is associated with loss of androgen receptor, loss of PSMA. Not the most common subtype of prostate cancer, but very important to recognize as there are therapeutic implications as these tend to be quite aggressive and need alternative treatment strategies. And when we look at patients that are dying from prostate cancer with the introduction of potent AR therapies, it seems as if patients dying with AR negative neuroendocrine prostate cancer is increasing. This is data from the University of Washington Rapid Autopsy Program, and these are also presumably PSMA negative. So I mentioned that androgen receptor can regulate PSMA, interacting with cofactors, and loss of AR is associated with loss of PSMA. But what Martin Bucht in our group found actually is that this relationship is not absolute. There are sometimes tumors that lack androgen receptor but still express PSMA. Shown here are some five neuroendocrine prostate cancer model systems just to illustrate how 2 out of these 5 had strong PSMA despite no AR, also captured by imaging. And what Martin showed through a series of functional experiments is that cofactors can continue to bind, like HOXB13 specifically, can continue to bind the enhancer of PSMA even when AR is lost in these later stage neuroendocrine or AR negative tumors. And on the flip side, we can sometimes see tumors that have low PSMA but high AR expression. So AR is not the only thing that leads to PSMA suppression, and we and others have implicated epigenetic regulators in regulation and repression of PSMA expression in a subset of tumors. Shown here is another model, a metastatic model, where a prostate tumor metastasized to the liver, just to show that these liver mets, some of them are PSMA low or PSMA negative, despite being strongly AR positive, also reflected by PSMA PET imaging. Liver mets in particular seem to have lower or more heterogeneous expression of PSMA, even with androgen receptor being present, even those without neuroendocrine features. And this may contribute in part to why patients with liver mets don't seem to respond as well to lutetium PSMA 617 or potentially other agents as well. When we looked at what is happening in the tumors that have PSMA suppression, and some of the top genes and pathways that come up are really, again, reflective of the metabolic changes associated with PSMA expression and repression. And in this case, we found a high upregulation of amino acid transporter activity, which was interesting to us because this could be leveraged using flucyclovine PET imaging, which is an L-leucine analog. And indeed, we see PSMA negative or PSMA low model systems strongly expressing flucyclovine PET. More recently, we've been doing mass spec and looking at different metabolites that are associated with PSMA suppression, including downregulation, as you may expect, of B9 or folate, and upregulation of other metabolites that are associated with this loss of PSMA. And working with Heather Jacine, one of our nuclear medicine colleagues at Dana-Farber, we have a pilot clinical study doing combined PSMA and flucyclovine PET imaging to understand discordant lesions and understand what are the metabolic changes in addition to that are associated with that. Obviously, FDG is another metabolic readout that could be incorporated or illuminated as well. And we're also thinking about how do we best monitor patients, something that I think is a big hot topic in the field, and in preclinical models doing combined PSMA and FDG imaging, because we see that in patient samples after lutetium PSMA, while most responding lesions have PSMA suppression, we've observed that some responding lesions, as measured by Ki-67 and other readouts, actually retain PSMA expression. So there may be an opportunity to develop companion imaging when thinking about response biomarkers as well, in addition to PSMA. So target expression matters. PSMA suppression can occur in late stages of the disease, in liver mets, in AR negative, CRPC, and neuroendocrine prostate cancer. This can occur through loss of androgen receptor, metabolic dysregulation, epigenetic suppression, and potentially features of the tumor microenvironment. I think there's still a lot to learn about response and resistance to PSMA radioligand therapy, and it's not just based on target expression, and also how we can apply what we're learning in this PSMA field to other cell surface targets, as there are many cell surface targets in prostate cancer, and some of which are being developed as Theranostics, and it'll be quite interesting to see how we start using these in a complementary way. So all in there, I just want to acknowledge my lab, our GU team at Dana-Farber, many collaborators, and especially Martin Vogt, who led a lot of this work in our lab. He is a PCF young investigator as well. Thank you.
Thank you, Misha, for an excellent talk. We're going to do all the speakers, and then we are going to jump to questions and answers. Next up, we have Professor Louise Emmett, nuclear medicine extraordinaire from St Vincent's in Sydney, subspecialty interest in all things PET, particularly in prostate cancer and theranostics. We've had a very close collaboration over the last decade, really heavily involved in research in Australia and PI of many trials, including the ENZA-P and Primary 2 trial. Today, Dr. Emmett's going to talk on PSMA upregulation in the ENZA-P study. Over to you, Louise.
So it's such an honour to be talking today, and thank you so much for asking me, and particularly an honour to be talking after Misha. And I'm going to focus on the findings from the NCP trial, and particularly looking at some of the translational work that's been happening in NCP, looking at the upregulation of the PSMA receptor in the mCRPC space. So the NCP trial is a randomized trial that was undertaken around Australia, sponsored by ANZUP Cancer Trials Group and run through NHMRC Clinical Trial Centre. 15 centres were involved, and it was a randomized phase 2 looking at enzalutamide alone versus enzalutamide plus 2 or 4 doses of lutetium PSMA in men who had risk factors for early treatment failure on enzalutamide alone. So this idea for the NCP trial really came from a very nice preclinical work that was done, and Misha mentioned Martin Bacht, who did an excellent review of the relationship between the androgen receptor and the PSMA receptor in about 2015, so a long time ago now, which was excellent and showed that the androgen receptor and the PSMA receptor have this very strong relationship in the cell. If you block the androgen receptor, you get this upregulation of the PSMA receptor. So we did some work at St. Vincent's where we did serial PET imaging in patients with mCRPC commencing ARPI, and found that after 9 days on ARPI, there was this massive increase in PSMA expression in response to blocking the androgen receptor, and really developed this idea that perhaps this increased expression that these cells could do are an element of androgen resistance. So cells could increase this PSMA expression, may have an androgen resistant pathway with them. So the hypothesis of NCP is that we have a very heterogeneous clonal population in all tumour deposits in mCRPC, some low PSMA expression, some high PSMA expression. If you then use an ARPI or enzalutamide to block the androgen receptor, you get increased expression in those cells that are capable of or are androgen resistant. And then we need very bright cells in order to get good cell kill with lutetium PSMA. So by increasing the expression in those more aggressive cells, you get left with a population of lower PSMA expression, lower volume disease, more likely to respond to enzalutamide for longer. So that was the theory. Enzalutamide randomized 162 patients 1-to-1 to either enzalutamide or enzalutamide 2 or 4 doses. Patients needed to have mCRPC with a rising PSA, 2 risk factors for early treatment failure on enzalutamide, and a positive PSMA PET. And the primary endpoint was actually PSA progression-free survival. But we have recently also reported at ASCO GU the overall survival for NCP. So there was an 8-month survival difference between the enzalutamide and enzalutamide plus lutetium PSMA arms, 26 months versus 34, with a hazard ratio of 0.549. So very significant overall survival difference between the two arms, despite the fact that 38% of patients actually had a crossover and received lutetium PSMA subsequently after coming off trial. We also found a really good improvement in physical function, in overall health status, in the level of fatigue that the patients were experiencing on the trial, and the level of pain that the patients had throughout the trial with the combination compared to enzalutamide alone. And NCP is not really one trial, it's actually 2 trials. And the second trial is the translational component where we're looking at biomarkers. And this has been funded by PCF Challenge, and part of which I'm going to be talking a bit today. But essentially, we stuffed as many PETs as we could. Each patient had 6 PETs. They had 4 specs if they were on the experimental arm. We had circulating tumour cells and ctDNA taken at multiple time points to try and evaluate what's happening with the biology. And we should be looking at that in the next year or 2 in a lot of detail. So just looking at the molecular imaging, we had harmonized PET and SPECT across the 15 sites and did real-time central quantification. We quantified all of the images, so it's about 1,500 scans have been quantified now. And for the purposes of what we're talking about today, this upregulation, we're really talking about the first 2 images, first 2 PET scans that were taken, the baseline PSMA PET scan and the PSMA PET scan that was undertaken in all patients day 15 after commencing enzalutamide and before they received any lutetium PSMA. So on both arms of the trial, patients had a PSMA PET before commencing enzalutamide and 15 days after commencing enzalutamide. The predefined hypothesis with that was that if patient had early PSMA upregulation between the baseline and day 15 PET after commencing enzalutamide, this would be predictive and prognostic for progression-free and overall survival, and that this poor prognostic outcome would be mitigated with the addition of lutetium PSMA 617. We did this by quantifying the patient. So when we quantified to get a total tumor volume and an SUV mean or SUV max, we actually derive tumor regions using semi-automated software. And that's what these regions look like. So on the left, we had a patient who actually had increase volume and increase SUV mean and SUV max within 15 days. And on the right, we had a patient who had a significant reduction in volume, mean, and SUV max between the baseline and day 15 PET. We don't really know how often this occurs, how many patients actually have this increased expression in response to RP in MCRPC, and it looks like it was quite frequent. 68% of patients had any increase in SUV mean within the first 15 days on RP. So it happens reasonably fast, and in this patient population, it's very common. When we looked at the effect on outcome, so PSA progression-free survival, we could see those patients who actually had a rise, so any increase in SUV mean in the first 15 days, had a 6-month progression-free survival on enzalutamide alone. And if they had a reduction in SUV mean, so they looked like they were responding in that first 15 days, 12.5 months. So a significant difference in PSA progression-free survival on enzalutamide alone. And then when you added the lutetium to it, those curves joined up. So 13 months and 13 months, no difference at all in outcome, whether you had an increase or decrease in SUV mean. We got very deep responses on the ENZA-P trial, particularly with the combination. 95% of patients had a 50% reduction in PSA versus 68% of patients on enzalutamide alone. And when we look at the rise and fall, so if you were on enzalutamide alone and you had any increase in SUV mean within the first 15 days, your PSA 50% response rate went down to 63%. Correlative, if you had an increase in SUV mean in the first 15 days and you received enzalutamide plus lutetium, it actually went up. So perhaps there was a little bit of synergy there, increasing expression, maybe get deeper responses with lutetium. And if you had a fall in SUV mean in the first 15 days on enzalutamide, your PSA response just on enzalutamide alone was really very good at 89%. And similar, if you have a fall with lutetium PSMA, actually no difference at all between the two arms. So a rise or fall looks like it's quite important in terms of predicting how a patient will respond to enzalutamide and whether or not they will benefit from lutetium PSMA just within that first 15 days. So in conclusion, increased PSMA expression occurred in 68% of patients with MCRPC commencing first-line enzalutamide, so it's common. An early increase in SUV mean in the first 15 days is associated with lower PSA response rates and short PSA progression-free survival. And the short progression-free survival that we saw associated with an early rise in PSMA SUV mean on enzalutamide is completely mitigated with the addition of lutetium PSMA. And just thanking everyone involved in the trial, thanking PCF for the challenge award that enabled us to do a lot of the work that we're coming out with at the moment. It's just been amazing.
Thank you so much, Louise. This is really incredible data, and I think you're presenting more ENZA-P biomarker data at ASCO. It's a big ASCO. We're going to see, I think all of us are there in about 4 weeks' time, and there is so much PSMA. The ASCO abstracts have just come out overnight, the abstract titles. So I was having a look at them on the drive over here, and there's a whole dedicated session for PSMA Theranostics at ASCO, oral session, which is unbelievable. So it's turning into a bit of a nuclear medicine meeting. But I'm sure there'll be lots of questions about your biomarkers. But we're going to jump to Dr. Ed Kwan. I've already introduced Ed, medical oncologist who's come back from Canada, who's going to tell us about some amazing biomarker work that he and the Vancouver group have done from the therapy study.
Thanks, Michael, and thanks for the invitation to come and present a study that's really near and dear to my heart. I remember being an investigator as a newly minted medical oncologist, sort of all the way back in 2018. And this was the first study that I was a site PI for, and never could have imagined that sort of 7 years later I'd have a chance to present this data on behalf of my esteemed colleagues. And also, this has all been supported with a PCF Challenge Award to Alex White. So let's kick off. I think this audience really needs no introduction, but just a reminder that the therapy study was an ANZUP-led phase 2 open-label randomized control trial of lutetium PSMA 617 versus cabazitaxel in patients with progressive metastatic castrate-resistant prostate cancer. They had to add prior docetaxel, and AR-targeted therapy was permitted. And this is a very molecularly imaging selected subgroup, and they're the key representatives from the study. So with respect to the ctDNA correlative analysis, we took sort of samples from two key time points, and we asked questions, two main questions. And the first with the baseline samples with, can ctDNA abundance and genomic alteration status predict treatment outcomes? And then with paired samples from baseline and progression, what are the genomic mechanisms, if they do exist, that relate to adaptive treatment resistance? And just a bit of a primer for the uninitiated, just so we get the terminology right. When we're talking about cell-free DNA, we are discussing sort of short fragments of free-floating DNA from dead and dying cells. And the primary way these are sort of released is through apoptosis or necrosis. And in the physiologic condition, most of the cell-free DNA turnover is from our white blood cells and also from some epithelial cells. Circulating tumor DNA relates to the tumor-derived portion of cell-free DNA. And there's a sort of very simple formula that we can start to imagine how much ctDNA is in circulation, and that's the ctDNA fraction, which you'll hear a lot about in the start of my presentation. So that can be represented by the ctDNA amount over the total cell-free DNA amount in blood. And why do we care about ctDNA fraction? Time and time again, what we see is that it's strongly prognostic, not just in metastatic prostate cancer, but across different types of cancer types. And this is a study in Nature Communications by a postdoc colleague of mine back in Canada, Nicolette Fonseca, looking at nearly 500 patients with first-line mCRPC. And what we see is that ctDNA fraction relates very closely at the bottom left with metastatic site, especially more higher ctDNA levels in patients with liver metastases, and correlates extremely strongly with clinical outcomes. What we see is PFS with first-line treatment in the top right, and then as well as overall survival. But what I mentioned is that it's been prognostic in multiple studies, but it's never been shown to predictive. So we were quite awestruck when we came across the first key results from the therapy study ctDNA sub-analysis, and that is that lutetium appears to demonstrate greater activity in patients with low ctDNA. These are PSA waterfall plots on the left, and the summarized data is on the right, sort of summarizing the proportion of patients who achieve a PSA 50 or a PSA 90. I'll ask you to cast your eyes at the bottom row first. So in patients with high ctDNA fraction, the proportion of patients in both arms is roughly similar with regards to achieving PSA 50 or PSA 90. But as you scroll your eyes up, what we can see is that there is a favouring of lutetium arm in lower ctDNA fraction settings, and all the way that's most stark in the ctDNA undetectable or low group, with all patients in lutetium arm having a PSA 50 response and a very high proportion having a PSA 90. Unsurprisingly, undetected ctDNA was sort of translated, these strong biochemical responses translated to superior PFS, and we can see that most starkly with the ctDNA less than 2% group in the lutetium arm. And those forest plots, the first time we were looking at them, truly amazing, with a hazard ratio of 0.12, and this held up in a multivariable analyses as well that also incorporated PSMA SUV mean high. ctDNA fraction did remain strongly prognostic for overall survival in both arms, so there was no difference with respect to overall survival across the ctDNA categories. So I think the first key message from the first part of my talk is that ctDNA fraction is a candidate predictive biomarker for differential response to lutetium versus cabazitaxel. But that's with the caveat that this is a molecularly imaging selected subgroup of patients that are progressing after docetaxel treatment. So I think we have to sort of frame this within the inclusion criteria of the study. So I think deep targeted sequencing using custom panels has really become the workhorse of tumor genotyping in cancer. And this has been an interest of the Vancouver group led by Alex White and Kim Chi for a number of years now. They've been using bespoke panels to really get very high quality detail from cell-free DNA samples. And to sort of look at it from a crux, they have a sparse genome-wide panel, which gives you very nice data regards to large chromosome level copy number changes. But then more discreetly around sort of select genes, we see very detailed data looking at focal number copy loss and able to detect structural variants as well. And what that allowed us to do in the therapy cohort is really get as close as we can, a clear estimate of how many leftover functional intact alleles that we had. And that we really made sure that we got this right before sort of intersecting with clinical outcomes. And we focused on sort of high prevalence genes in our cohort. And one of those high prevalence genes was PTEN alterations. So these are forest plots looking at cross-arm comparisons with regards to PTEN alteration across the two arms. And what we can see is that there is a modest but statistically significant improvement in progression-free survival in patients with any PTEN alteration detected on ctDNA. But what's more stark is the overall survival improvement that you get 5 months for any PTEN alteration and 6 months for patients with no leftover copies of PTEN. To dive into that a little bit deeper and to visualize that, we can see these Kaplan-Meier groups trying to understand what is driving this. And what we can see here is that this differential outcomes are mainly driven by poor outcomes in the cabazitaxel group. You can see that the dark line is the alteration positive arm subgroup versus the light line, which is alteration negative group. And we can see that the biggest difference is actually mainly seen in the cabazitaxel arm, both for PFS and overall survival. We looked across at a number of other genes as well, and we didn't see any differential predictive utility with regards to TP53 alterations. And as Misha mentioned earlier on, we were very also interested in AR alterations, this intersection between PSMA pathways as well as AR alterations. And surprisingly, we didn't see any differential outcomes there either. Of course, we had to look at DNA repair alterations, and the angle here is thinking about radiosensitivity. We know that DNA repair genes are really important in the repair of double-strand DNA breaks. So could these serve as biomarkers for lutetium sensitivity? And we're very careful here, obviously, with smaller sample size, but we do start to see some activity in certain genes, including ATM, less so in BRCA. And maybe the reverse correlation for CDK12 alterations. We can see in the bottom right-hand corner sort of a schematic of the PSA response and the depth of PSA response across different subgroups. So I think the second key message is that ctDNA genomic analysis may expand the scope of relevant biomarkers that help prioritize lutetium against other standard of care options. So in the final minute of my presentation, I want to talk a little bit about the resistance alterations that we were looking at. And we took a very multi-pronged approach exploring population shift and kind of subcategorizing into two main changes that we were looking for. One was looking at mutation-driven changes, and on the right is copy number-driven changes. And these are sort of per-patient profiles. And on the left, in patient 279, what we can see is at progression, the emergence of a number of new mutations that are occurring in the setting of lutetium treatment, but less so, really no changes in the AR copy number or the genome-wide copy number traces. This is in contrast to the patient on the right, where we see that there is a marked increase in AR copy number and really a restructuring of the genome-wide copy number traces there, but not many mutation changes. And we sort of did this across the whole cohort, about 106 paired samples. And the main takeaway I want you to get from this is that neither lutetium nor cabazitaxel really substantially reshaped the mutational landscape. And at progression, yes, we do see some new alterations in key prostate cancer driver genes, but these weren't occurring more often in one or the other. And importantly, there were no treatment emergent FOLH1 mutations, and the same for copy number changes. So I think the third key message is that there's no evidence of any recurrent acquired genomic resistance mechanisms for cabazitaxel or lutetium. And really that does make us think, okay, well, if there aren't any genomic changes, where should we be looking? And the data that was presented before from Misha about epigenomic changes is quite intriguing. I think the conclusion is that there are now sort of a smattering of potential candidate predictive biomarkers that might inform lutetium treatment. And some of them are favorable in green, some of them may have negative implications in red, and some are more neutral, such as AR alterations. And this could serve as a bit of a framework going forward as we investigate all these different cohorts that have been mentioned by Louise and others. So I really want to thank the Wyatt Lab therapy team, especially Sarah Ng, who's a bioinformatician in our group, has really been sort of extremely helpful in the last 2 years, keeping me under control. And this wouldn't have been possible without Sophie Tolmai and Cameron Herberts, who are postdoctoral fellows. Cameron, as of this morning, has announced that he has a new position as a translational scientist at Natera. So if you're watching, Cameron, all the best for a very bright future that going forward. And finally, I'd like to thank the PCF Foundation that have supported this through a PCF Challenge Award. Thank you.
Thanks, Ed. And this work, is it published yet?
It is. We found out very, very recently that a couple of weeks ago, actually. So it's, we're coming out soon in Nature Medicine. So please look out for it, but extremely happy news to see that.
Congratulations, Ed. And are we going to see more therapy biomarker work at FASCO?
Absolutely. So I'll try and keep the lid on that, but then we might start to see some interesting signals with regards to potential toxicities that some of our treatments may be inducing.
Well, the titles are out this morning, so we can disclose it.
So it's looking at clonal hematopoiesis in the therapy population and whether or not there's any emergence of these mutations in these hematopoietic stem cell populations. So stay tuned.
Very good. That will be an oral abstract at ASCO. So our last speaker before we do a deep dive Q&A is Professor Marty Pomper. Marty is Professor and Chair of Urology at UT Southwestern Medical Centre. He's received undergraduate and graduate degrees in both chemistry and medicine, which is a pretty unique combination and really the perfect combination for Theranostics. And he's had a very successful career at Johns Hopkins, where he pioneered development of DCF-PYL, the fluorinated PSMA tracer that's really used globally, including at our centre in Peter Mac. And he's been faculty there until recently. He has an interest in the development of new imaging and therapeutic agents for cancer, both, and also CNS disease. And today, Dr. Pomper will talk to us about what we can learn from PSMA, reflections on, really a couple of decades of research in this domain. So really looking forward to your talk, Marty.
Okay, first I want to say thanks for inviting me to do this. It's really a pleasure and honor. It's great to see my old friend Howard Soule. And, Howard and PCF were, if not the first, among the first people that funded our work in PSMA, maybe in the late 90s or early 2000s. So thanks very much for that. So some disclosures. So what I'm going to talk about are basically 5 things that I've taken away from PSMA over the last 30 years since I started thinking about it. So let's first start by talking about synchronous and metachronous metastases. So synchronous metastases are basically, they're present either at or very soon after diagnosis. Metachronous metastases are detected a little bit later. My friend and colleague, Steve Rowe, was a co-author on this paper. He called this paper to my attention. And you can see this chart, which is a little bit complicated. It shows how over time, the association shown by R between the rate of synchronous and metachronous metastases for a variety of cancers has been increasing, as shown by the 5, 10, and 15-year survival data. But interestingly, if we take a look at the clinical FDG PET use rate, you can see how the incline in that correlates with R, which is what's showing synchronous and metachronous metastases showing up at roughly the same time. So what that really suggests to us is that by using more sensitive imaging like FDG PET and molecular imaging in general, we're increasingly going to identify more lesions at presentation for more accurate diagnosis and for staging and management. So for what I like to say for PSMA, we're basically at the point now where biochemical recurrence is almost like recurrence, so we can actually see the lesions and get a fairly complete picture of the extent of disease, or at least the PSMA positive disease, right at presentation. So better imaging does seem to make a difference. So how does that actually manifest? Well, I'm going to show a couple of examples. So what's nice about a good imaging agent is that we can use it for lots of different therapies. So we can use it, for example, to enhance radiotherapy. So here, this just shows how PSMA PET imaging, rather than just conventional imaging, can help guide stereotactic therapy of oligometastatic disease as those METs come about. So some patients in this study that was led by Phu Tran, one of my former colleagues at Johns Hopkins, showed that SABR, based on conventional imaging, produced a lower distant metastasis-free survival than SABR based on the PSMA PET. So according to Phu, he says that total consolidation of PSMA-avid lesions may alter the natural history of the disease. So that was Phu's opinion a couple of years ago. But the point is that if we use the molecular imaging, the precision imaging PET for directing the therapy, we get a little bit better result. In a second example, bipolar androgen therapy is a sort of an experimental therapy that was developed by one of my former colleagues at Johns Hopkins, where patients are injected with supraphysiologic testosterone while they're kept on androgen deprivation. This does seem to kill, it sort of freaks out the prostate cancer, and it does seem to work in a number of cases. So here we were using PSMA PET to see who might be at high risk of progression while on bipolar androgen therapy. We studied 6 patients, and in 3 of them, you could see in the blue, the 3 patients in blue, they tended to get a little better. 4 through 6 tended to get worse over time. But the main issue is that if we looked using conventional imaging in 3 months, everybody looked like either they were stable or they were getting better. So they were either having an objective response or they were stable. But that was with conventional imaging. With the PSMA PET imaging, patients 4 through 6, you could see that at 3 months, they were already looking worse. So we got a 3-month lead time to predict that those patients also were going to progress. So the bottom line is that we have a little bit of lead time to help with management of these patients than we wouldn't have had if we had just done conventional imaging. So the imaging really does make a difference. Number 2 lesson that I've taken away is that there's always room for innovation. So, I mean, it sounds obvious, but I can tell you that back in the 90s, when I first started thinking about this and writing grants, I mean, the first grant I wrote was around this time in 1996, 97, that this already existed. So the 7011 C5 antibody had been radiolabeled. It was used for imaging. It was called ProsTIC. The urologists were not really using this very often. And when I would write grants, everybody would point to this antibody and they'd say, hey, we're done. We have this solved. And I was, going to give up. But then I was at Sloan Kettering and I talked to Howard Scher, and who was a medical oncologist, a GU oncologist there. And Howard, he did agree that these antibodies, not this particular version, but the J591 antibody, really did teach them these new patterns of metastatic spread of prostate cancer they'd never seen before. And he said, yeah, these antibodies are great. But then he shrugged his shoulders and he said that, but we can't use them. And I said, why not? And he said, well, because we got to wait a week after we inject them. We need something that we could, integrate into clinical workflow. So the lesson that I took from that was, and that really changed my whole attitude, just talking to Howard for 5 minutes. And it is that we really need to work more closely, with the experts, the clinical experts, and they will tell us what they need, and their word is really what can keep us going. So then we persisted, and we made the small molecule agents, and eventually, we showed that the pharmacokinetics were very good, and we can integrate them into clinical workflow. Okay, number 3, shoot first, ask questions later. So what I mean by that is that when we began making some of these early compounds, all that really all that I knew about PSMA was that it was present in higher levels in prostate cancer than a normal prostate. We knew that, and we knew it was on the cell surface. No biology. So the shoot first is really just developing the tools to look at what could in the future be proved to be a valuable biologic target. So this study, or this compound, we first made it in around the year 2000, and to test the binding specificity, I didn't even have any LenCap cells or any prostate cancer. So I used the murine kidney as a surrogate target for PSMA, and we just did a kind of a dose saturation there. So we didn't really know anything about the biology, but I had a feeling that this was going to be a useful thing to go for. So in fact, at the time, PSMA was really, or these small molecules, as well as the other affinity agents, the antibodies, were really just thought of fairies for bringing, like antibody drug conjugates, or you bring in a toxin or an imaging agent, and that there was really nothing all that interesting about PSMA compared to the androgen signaling axis, which of course has been very well developed and interesting. And here you can see now the ask questions later is we're starting to ask questions about what PSMA does. And you could see there's all sorts of brilliant biology that's going on. We've heard some really amazing, I probably tripled my knowledge of PSMA biology just in the last 45 minutes. Really brilliant work. In fact, I highlight some of the work here by Dr. Beltran's group. Really great. And didn't know any of this just a few years ago. So it's amazing what's coming out. I'm not going to get into any of that because we have some real experts here on the talk on the online that have shown that. A number 4 out of 5, almost done, is the literature. So I would advise, if you're a young assistant professor, that's the only time that I ever had to really get deep into what I was interested in, really read the literature. And I read vociferously back then. I was a neuroradiologist, actually, and I was interested for many years in enzymes that produce glutamate in the brain. And I came across this paper in 1996 where this nalidase enzyme produces glutamate. So I thought maybe we can make a positron-emitting version of some of these compounds in this paper, and we could figure out what's happening with glutamatergic neurotransmission in the brain. But the compounds were very hydrophilic. They probably weren't going to get into the brain. I wasn't, I kind of put it on a little bit of a back burner, but just for a couple of weeks, because I came across this paper, same year, 1996, and this shows that this nalidase was PSMA. So I just gave up on the brain, to heck with that, and just pivoted everything toward prostate cancer, even though I was a neuroradiologist, because I thought, wow, there's no prostate there might be a blood-brain barrier, but there's not really a blood-prostate barrier. We can use that to image prostate cancer. There's a big unmet need because FDG PET wasn't working very well. In fact, at this time, FDG PET wasn't even approved for clinical use. So I thought it was a good unmet need. So I like to show this famous paper by Michael Hofman's group. Actually, I don't have the paper that this goes with. This was given to me by Jonathan Simons in real time. So I guess Michael must have given this to Jonathan. And then I ran into Jonathan in a meeting, and he was, how John, I don't know how many of you know him, but very excited, energetic guy. And he like stopped me in my tracks. He says, "You got to see these pictures. You won't believe it." And he showed this to me. And what it shows is how you could take patients with PSA levels of close to 1,000. And it's just remarkable how the tumor just seems to melt away. This is an early study with Pluvicto. And I just want to note that as far as Theranostics are concerned, I think we're really at the beginning, because despite the fact that we see this remarkable decrease in tumor mass, of course, it's just PSMA positive tumor mass. We see this remarkable decrease in tumor mass. We have fantastic improvement in quality of life, shown here on the right. The Kaplan-Meier curves, to me, are still disconcertingly close together. And, why is that? Well, we're learning why that is from, others on the call, quite frankly. But I think that as we learn more about biology, like we're doing at this meeting, I think that more markers are going to come about as we just learned. I just learned about the ctDNA and other markers. As those markers come about, the Theranostics will follow. So what I'm hoping is that eventually we'll be able to, treat patients based on what markers are showing up in their tumors. Whereas already people are starting to pivot PSMA toward renal cell cancer and other cancers, and maybe just see, what markers are there. These other markers might be in there. Hopefully there'll be a theranostic to go with it. And that way we can really approach cure. And I'm hoping that there's a cure somewhere on here, or maybe on another wheel like this that can be rewritten in a couple of years. And with that, there are too many people to thank. So I thank you again for inviting me to talk. I've learned a lot, and I really appreciate it. Thanks, Michael and Howard.
Oh, thank you, Marty. That was extraordinary. In fact, all the talks were extraordinary. I have a lot of questions myself after all those talks, but maybe Louise, you can, we've got about 25, 30 minutes for questions. You can take us through all the questions that are asked. We might elevate some people to the panel from overseas if they have their videos and audio ready as well.
Yes, thanks so much to the audience. We've received a number of excellent questions so far, so keep them coming. I'll start off with Silky's question, which is probably more directed to you, Louise. So Silky's wondering, ADT seems to decrease PSMA expression rather fast after starting ADT, whilst enzalutamide increases the expression. Do you know what happens with the PSMA expression when we're giving both ADT and an ARPI in the metastatic hormone sensitive space?
So you've hit on an area where we really don't have an answer. I think the reason why enzalutamide looks like it increases PSMA expression is because we've tested it in mCRPC, not because it increases PSMA expression in hormone-sensitive space. There is one paper which looked at the combination of enzalutamide and ADT in men with high-risk metastatic localized disease with nodal involvement prior to radical prostatectomy. They put them on ARPI and enzalutamide, and they did a pre and post PET prior to radical prostatectomy, and 80% of those patients lost all of the target. So we know that with ARPI, it goes down as well in the hormone-sensitive space. Megan Crumbaker is actually doing a serial PSMA PET study in MHSPC, and I can tell you as one of the readers that that's also happening in those patients at 3 and 6 months. People lose their target with both, and I would expect that to happen.
Thanks, Louise. Jeremy also has a number of questions for you, so I might actually let you ask your questions, Jeremy, if that's all right, because you did have a couple for Louise as well.
Jeremy, I'm trying to promote you to the panel. if you can accept, that'll be great, and you can ask your question. We'll give you a few seconds. We were just in UCLA for the UCSF PSMA conference run by Jeremy Calais and colleagues. It was a real fantastic meeting. I enjoyed it a lot. You did a spectacular effort with that meeting, Jeremy. It was really something else. But you had a few questions, so fire away. You can choose which panelist you want to direct it to.
Yeah, hi everyone. A pleasure to be here. Thanks, Mike, for putting me there and organizing that. It was also a pleasure to see you in Los Angeles. Questions for Louise. This is of high interest, the overexpression potentially induced by AR-targeted agents of PSMA, both for the scan sensitivity, for potential treatment efficacy. So I have many questions on that. I try to replicate that in our studies, and the results are inconsistent. So first question, the time frame. When do you think this overexpression may happen in, let's say, an AR switch, castration-resistant setting? You switch the AR, and then 9 days, 15 days, 30 days, and how long that would last? That would be the first question.
So first question, I think, so the studies that have been retrospectively have often done the change in PSMA PET between baseline and 2 to 4 months. So it's very variable. And some of the baseline PETs, they were already on the ARPI. So they weren't entirely, new, definitely not an ARPI, and then definitely on an ARPI. So I think retrospective is very hard because the timing of the PETs is extremely important. The other thing I would say is we did baseline at day 15 because we wanted to eliminate those patients who actually just had progression. But if you do baseline in 2 months, it might be those patients who are progressing already. And what we have within NCP is the day 92 PSMA PET as well. What we're planning to do in NCP is check the baseline day 15 and then the day 92 and have a look at true progression versus not true progression. So androgen resistance not responding versus flare in PSMA expression. I think they're two different things. So I think it's a really important question. How long does it last for? Does it mean that we can't identify disease progression with PSMA PET on serial imaging? And I'm hoping that the day 92 PET, which we are just about to start analyzing in NCP, will answer that question for you. But I think retrospective studies looking at upregulation, downregulation, if you don't know exactly when you started, is extremely difficult. So I think they need to be prospective.
Thanks, Jeremy. Do you have one more question?
And how do you define overexpression on a whole body PSMA PET scan? You extract quantitative parameters. You would look at the overall SUV, maybe the overall tumor volume. And what threshold would you consider positive for increased expression?
So we used SUV mean. And the reason that we used SUV mean as looking at the voxel intensity of all the deposits within the tumor load itself. And the reason we used SUV mean is because we believe the reproducibility of SUV mean and its variance is much lower. It's a mean. So that's what we've done. But obviously, we would need to look at the, if you put someone on a camera twice and you did an SUV mean within a few minutes of each other, what's the variation in that? And also, if you looked at the quantitative analysis, what's the variation in that? We need to do all of that. And so I don't really have an answer, but I think we should be using SUV mean.
Yeah, they're great questions. We have a question from Danny Mena, who's a nuclear medicine physician from South America. We'll bring him into the panel to ask your question. We recently did a Lancet Oncology commission in radiotherapy and theranostics, and it was a bit of a global review, and it really highlighted the inequity of access to theranostics. It's great to have it in the US now and Australia, but it's really inaccessible in many countries. So I think you have a question along those lines, Danny.
Yeah, thank you. Thank you so much, Michael. And the question is actually going to be for you that are going forward a lot of time about promoting PET PSMA all around the world. But the thing is, in Latin America, we have a huge issue about access because everybody's talking about PET PSMA and how could contribute with the staging, with relapse and everything, and even, of course, for selecting the patient for therapy. But right now that Novartis, for example, is going forward to the market, The huge problem that they have is that we have no access to PET PSMA in Latin America. In Mexico, we have just less than 5 cyclotrons producing PET PSMA, fluor PSMA. Then we have Colombia, less than 3. Chile, 1 cyclotron producing fluor PSMA 1007. So my question is, in this situation that we have in Latin America with no good access to PET PSMA, but we have access to a SPECT PSMA with technetium in many of the countries, especially in Mexico, that we are using more than 7 years technetium PSMA, maybe could be a recommendation to replace or jump in these countries with no access from PET PSMA to technetium PSMA, SPECT PSMA, and especially because also we have technology to supply the calculation of SUV min, SUV max that could be done in an SPECT camera using this technology. So what do you think about it? Maybe a recommendation about using SPECT PSMA as an option to selection criteria could be an option in regions like Latin America?
Yeah, it's a great question, Danny. So I think, this technology is becoming more available. I've got a graph which I can't show you, but in Australia, 10 years ago, there were 2 places doing a PSMA PET. Now you can get it at more than 140 PET scanners across the country. And I think, Marty, that's probably replicated in the US as well. Do you know how many PET scanners there are in the US and how available a PSMA PET scan is now compared to 10 years ago?
Yeah, that's, I can't tell you how many there are. I have a slide like that somewhere. But yeah, there are lots of PET scanners, particularly in major metropolitan areas. It's not hard to put these agents on a plane and get them to where you need to. Lots of cyclotrons coming up. I know, for example, there's one company, which will remain nameless, that only had 2 or 3 cyclotrons, but then they started, producing one of the F-18 compounds, and within about 2 or 3 years, they have about 24 or 25 cyclotrons. So I think it's a matter of resources and priorities. I think that there are, SPECT is a perfectly good way to do it too. If you want to start using technetium or even maybe I-123, there are a lot of good compounds. I mean, the thing about PSMA is that it's a very promiscuous receptor. So as long as you have a glutamate on one side of the molecule, you could put a Buick on the other side, and you'll be able to. That's a large American automobile. You can still bind to PSMA. So yeah, SPECT agents I think are good, but then I would leave it to Michael and others to develop criteria, specific criteria by which to select patients. But yeah, it has really, PET has grown. It's the second major indication for PET beyond just FDG. So I could see that happening in Latin America. And I know that there are places in Brazil and elsewhere where I've been that, where they are doing a fair amount of PSMA PET.
Yeah, I think globally, PET is still the fastest growing modality in imaging, and SPECT is actually not growing, even in places, developing countries like India. Many new centres have a PET scanner, but not a SPECT scanner anymore. So I think we will see a progressive shift over the next 10, 20 years where PET is increasingly available, even in low income and developing countries, and the costs will come down, hopefully. In India, you can get a PSMA PET scan for a couple of $100. It's quite extraordinary. Even in Australia, you were able to get a PSMA PET scan for about $650 today, and it's now reimbursed, so patients don't have to pay, and it's growing double digits still. So I think availability will be sorted out. Supply, demand, the market has a way of working itself out.
Thanks very much, Danny, for that question, and Marty for that excellent response. So we'll keep going through the questions. So Janet Reed has 2 questions which are really common clinical scenarios we see in the clinic with patients receiving lutetium PSMA. So I might ask the first one to you, Misha. So Janet's asking, what could be an explanation for fairly extensive PSMA avid skeletal metastases in a patient who has fairly low PSA expression, for example, only 1 to 2 nanograms per mils?
Yeah, thanks for the question. I think it's this complex relationship between AR target genes. You can have PSA low, where PSMA is high, which is not a direct AR target gene. And so I think it's quite fascinating, just even the data with the bipolar androgen and the enzalutamide that was presented, where you can see PSMA going up despite, I'm sure, the PSA going down at day 15, and whether these are, on target PSMA reactivation versus flare, as was mentioned. And so I would say that this, it's not always the case. While you assume that someone with a low PSA is going to have low PSMA, it's not always the case. And so I wouldn't necessarily use PSA in itself to preclude getting a PET scan to look for candidacy for PSMA targeted therapy if the other sort of clinical parameters are consistent. I do think that low PSA progression is reflective of something, obviously, just like low PSMA, where you think about these androgen independent variants. But I would say that relationship with PSA is not absolute. It's kind of an indirect answer to your question. But I don't know if anyone else has. Louise, if you have any more comments on that relationship.
Yeah, I think it's super interesting. You don't have to have both of them. So heterogeneity, we lose receptors. It's a part of, sort of de-differentiation of the cancer cell. Forget how to express PSA, forget how to express PSMA, I put it very simply. So I'm totally agreeing. You get both, and neither of them probably are a good sign, right?
Thank you. I think there's a lot of interesting data as well, looking at other biomarkers like ctDNA on treatment and how that compares with PSA and possibly is a better biomarker as well. So Janet's next question is another really common situation. So she's asking, why do some patients who seemingly have an appropriate phenotype for treatment with lutetium PSMA, so they've got PSMA avid disease with no discordance on FDG PET scan and good uptake on the post-therapy SPECT CT, why do they stop responding to treatment? Louise, did you want to answer that one?
I wish I knew. So I think radiation, when we look at patterns of progression on PSMA PET or SPECT after lutetium PSMA therapy, the majority of patients actually have persistently positive PSMA avid disease, and often it sits around an SV max of 16. So they're still bright. So we have radiation resistance that's been induced. We've developed radiation resistance. I think Ed could possibly talk about this. He alluded to epigenetics, and Misha should talk about epigenetics. What is the epigenetic involvement of radiation resistance in response to lutetium PSMA, and how can we overcome that? What do you think is actually happening in the cell? I don't know, Ed or Misha?
Misha, I might let you comment on
I would say that I don't know what's going on necessarily. I think, radiation resistance is really, in the context of lutetium, is still, I think we're still learning a lot about what those tumors look like. And I think we need more translational studies with biopsies and liquid biopsies to better get at that question. It's, from the data that Ed showed, it doesn't seem to be necessarily a mutation that's driving resistance that, even in those patients that have, strong PSMA expression. Epigenetics can obviously lead to heterogeneity of expression that can influence resistance, but also upregulate lots of other genes and pathways that can occur in these very resistant tumors. And there's obviously different patterns of resistance after lutetium too, and I think understanding that spectrum, through more studies is still needed.
And just to add to Misha's comment there, I think the techniques and the technologies that are being used to profile ctDNA epigenomic profiling have really expanded very recently. The number of papers looking now at plasma ChIP-seq, looking at histone modifications, as well as methylation techniques, 5-hydroxymethylation, methylcytosine. It truly is a rapidly expanding field, and I think our ability to profile this in a minimally invasive manner is going to change quite dramatically going forward.
I see a question from Daniel Valenzuela, who's one of our previous fellows from Santiago in Chile. And His question is, which radiotracer is most appropriate for imaging neuroendocrine prostate cancer? So I'm going to be simple and just vote for FDG. I think it's a fantastic tracer for de-differentiated prostate cancer of all types. But Marty and Misha, what would you use?
Well, Misha had a very convincing argument for using flucyclovine. And I think that, they have some very nice data behind that. I think that there are a couple other possibilities. I think that some of the FAP tracers have been shown to be taken up in the neuroendocrine form. And I like that there was a slide that Misha showed where CEACAM5 is on there. I think that's another possibility. So I think looking at some of those other markers. But as an aside, I remember when we first started doing PSMA PET, seeing a liver with all these big blank spots in it, and it totally destabilized me. I said, OMG, these tracers are failures. But we subsequently learned there are other causes of prostate cancer and other, it is very dynamic, it's evolving, it's heterogeneous in 5 different ways. But I think that, there are new markers coming out. I mentioned the ones that I like. I think that there's going to be more possibilities coming out in the near future.
What do you think we'll be using, Misha?
I agree. I also would add DLL3 to the list, which is a nice cell surface marker. I would say, I do think, obviously these are mostly FDG avid. I think it depends on what you're using the PET scan to do. Is it going to guide a biopsy to try to look for this, very nebulous definition of neuroendocrine prostate cancer sometimes? And how is that going to impact your next line treatment? So right now, I would say, using FDG especially if you see PSMA low or PSMA negative disease to confirm, if there's a question of responding, non-responding, or just do a biopsy, really at the moment. But I would hope that in the future we could, have an imaging modality that could help us avoid biopsy and be able to offer some, new treatment modality based on that.
Ed, there's another question for you about, I think, your recent findings and poster. So Raju was wondering, is it low ctDNA or high PSMA SUV mean in the therapy study that you think is the strong predictor, or are they additive? And do you have any idea why high PSMA expressing patients might have low ctDNA?
Thanks, Raju, for the question. And this is data that I didn't get a chance to present today, but when we were first looking at correlations between ctDNA fraction and both imaging modalities, baseline PSMA SUV mean and FDG metabolic tumor volume, we did see some very interesting correlations. The first was that ctDNA fraction correlated very strongly with metabolic tumor volume by FDG. That wasn't too surprising. And that kind of comes back to Michael's comments about whether or not that could sort of portend more aggressive disease overall with the higher ctDNA fraction. What was interesting, though, we saw this inverse correlation between sort of high ctDNA fraction and low PSMA SUV mean, or to put it another way, sort of low ctDNA fraction patients had much higher SUV mean, much higher than 10. And what we think is that potentially ctDNA fraction could be a reflector of overall tumor heterogeneity in the space. So, the model that we're thinking of is, in patients with low ctDNA fraction, do you have more highly PSMA avid, more homogeneous expression in the tumor site? And in high ctDNA fraction is a sort of more de-differentiated, more FDG disease within that tumor deposit. So that's sort of the framework that we're thinking of.
Yeah. Thanks, Ed. And on that note, in terms of the data you presented on tumor suppressor genes, so there's a question from Rick Davis about P10. Is that the only one that may be less deleterious to PSMA therapeutic treatment?
Certainly, we also looked at TP53 alterations as well, and we didn't see any differential effect. It seemed to be a global poor prognostic marker, irrespective of the type of treatment arm you were that patients were being on. So both in the lutetium and the cabazitaxel arm, patients with TP53 alterations did much worse, and that kind of fits with data from other tumour streams. Our numbers were a bit low for RB1 alterations, so that's something we will have to look at going forward.
Marty, there's a question about J591 not being a viable antibody 25 years ago, but is it today?
It's viable. Not so great for imaging, for clinical imaging, but certainly I think for therapy, it's I think that Neil Bander's shown that by itself or combined with some of the small molecules, leveraging the advantages of both platforms, I think it is viable. Purely for imaging, I think that there are better possibilities.
Now, Ed,
Howard Shear, at the time just felt that, it was hard to inject patients and wait a week and scan them.
Thanks, Marty. Just trying to do some rapid fire questions before the end.
Keep it to less than 10
seconds. To keep, there's a question about correlation between ctDNA and FDG uptake. Some people don't like doing FDG scans. They may not be reimbursed or approved. Do we need an FDG, or can we just take a blood test instead?
I think that the main difference is that the FDG is giving you spatial information that ctDNA isn't able to give you. The contribution to the ctDNA milieu is potentially from multiple metastatic sites. So I think I'm not quite ready to sort of remove FDG PET imaging in this space, mainly because of the added benefit of having spatial information.
I have a question for the audience. How are we going to define PSMA expression? If you can vote for this question. Can you see that on your screen?
I can.
Yeah. How will we define low PSMA expression in 5 years' time? Will it be a PSMA PET with an SUV max, SUV mean, or just a visual assessment, immunohistochemistry, pathology, or will we use a liquid biomarker, Ed style? Everyone can vote, and I'll give everyone about another 5 seconds to vote. We still have a couple of hundred people online, so it's pretty impressive. And over a third of people have put in a vote, which is even more impressive. And I will end the poll and share the results, and you can see that most people think we'll be doing an SUV mean. That would have been my preferred answer, but I would have thought most people would go with visual analysis since it's very simple. What do you think about that, Marty? Do you think we'll be using more advanced methods or just looking at scans with our eyes?
Well, I think that once that these biomarkers are sorted out, that combined with the imaging, I think together would be the best way to pick the right patients, for the right therapy. Biomarkers are also going to tell us what therapy, hopefully, that we can use, whether it's cabazitaxel or one of the lutetium or actinium.
Misha, are you able to get an SUV mean out of your nuclear medicine doctors today, or is that still a struggle?
That's
not in real time, but maybe with AI work and all the work by you all, we'll have that soon.
Louise, what do you think about how we'll be interpreting PSMA PETs in a few years' time?
I think we're getting closer. We're getting a lot closer to having quantified programs that don't need involvement. We need to have a radiologist who doesn't do anything, and we have a reproducible FTV mean. That's what we need in order to make it available to Misha.
There's another question about what is the maximum number of lutetium PSMA therapy cycles in the future? I think, Michael, you recently published a paper about a patient at Peter Mac who'd received 20 cycles. Do you have a specific number in mind for what the maximum number is?
Well, this was a special patient because it was actually Ed's patient over at the centre he used to work for, and then he had 6 cycles on the therapy trial and then came across to us at Peter Mac for another 14 cycles. So this patient had 20 cycles. GFR was normal after 20 cycles. That's over a 4.5-year period. He had, grade 1 thrombocytopenia, and he actually had cabazitaxel after 20 cycles. So clearly we can give a lot more. And we give up to 10 cycles to really many patients in our centre. So I'd like to see that FDA approval be extended? Because there are a group of patients who have really incredible responses, and limiting them to 6 is challenging. What do you do, Marty and Himisha, in the US currently in that setting?
We can only give 6. But I think that the concept of retreatment or taking, breaks and what's the timing of that, or continuing treatment, I think that there's much more to be done than just sticking with, the 6.
Yeah, 6 is it. But I think that we have to get some more data about long-term effects, before we start doing that here in the US. But I've always wondered whether we're treating enough, or if patients could tolerate more. The fact that we do have patients that drop out, of their, they even don't make it through 6 full cycles, makes me think that maybe we are treating them already adequately, although that's a very hotly debated point.
And we probably have time for one more question. So the last one is regarding radiation resistance. In response to lutetium PSMA, do you think this could be affected by the timing of when we give it? There's obviously lots of studies evaluating lutetium PSMA much earlier in the castration resistant, but even earlier in the prostate cancer course. Do you think that would affect radiation resistance? And would this differ with other radioisotopes such as alpha-targeted therapy? Louise, did you want to start with that one?
Sure. So I think we haven't even started to look at how we impact depth of response and knocking off radiation-resistant clones by increasing dose. Scott Tagawa did that great study where he gave 22 gigs in 2 weeks and got very, very good responses, but then didn't follow up with further doses. So we definitely need to do that. We need to do it with lutetium. We need to do it with alphas. We need to look at fractionating. Radiation oncologists fractionate 5 doses. They don't give it over 30 cycles anymore. Why are we giving 6 weekly treatments? We need to think much more about how we're giving it, and I think that will have a big impact on outcomes.
Well, I think we're going to wrap it up. That is, it's been a great session. Thanks to all the panelists from joining from all around the world. Thank you to Declan Murphy for hosting in the GUcast studio. Howard, I'll let you say the last words together with Andrea.
Well, I was quoted by Declan Murphy at your scientific meeting. When was that, Michael? The ProsTIC conference in Melbourne well over a year ago, that we need new targets and new drugs and a lot of new biology, new targets and new atoms. And nobody's doing more of that than the Peter Mac right now. We need the whole world to light up, if you will, and discover new targets and new atoms. And thank you for a great webinar today.
Thanks so much for enabling all of us around the world. It's an incredible enterprise, the PCF, supporting actually many of our young investigators that enable all this work. So we're very, very grateful. Look forward to seeing some of you at ASCO, and do tune in to GUcast on a regular basis, and we will have another PCF ProsTIC webinar in the near future. Thanks, everyone.